I'm Zarina Ali. I'm from the University of Pennsylvania. Looking at pathologies from a diagnostic perspective, when is it spine, when is it peripheral nerve, when is it both? How do we distinguish these lesions, and when and if we treat both? So I think it's important to sort of go back to the hypothesis that first brought this up, which is double crush syndrome, which is a controversial hypothesis. The idea is basically that there are serial compression points along an axon, each of which may be insufficient to impair clinical function, but the collective effect of both lesions can result in what's called double crush syndrome and result to nerve dysfunction. This is a very controversial topic. There have been several studies looking at this from both an electrophysiologic standpoint and pathophysiologic standpoint. And the controversies really arise in that there's no good way to objectively verify that symptoms are causally related to the pathophysiology at both levels. There's this notion of also the bias of subscribing DCS in patients when they have failed surgery or failed treatment from any one of those pathologies. And the other problematic issue becomes that it may encourage an additional surgery at another level that is detected, say, on EMG, for example, when you see a patient who has, carpal tunnel syndrome reported on their EMG, and that may not be the most effective treatment option for that patient. So it remains controversial. However, I think most of us that treat patients with both spine and peripheral nerve conditions would agree that there are multiple etiologies that contribute to nerve dysfunction. The literature will quote anywhere from 6 to over 70% of patients that have multiple sources of nerve dysfunction. Again, recognizing that there's not a clear causative role. There may be common extrinsic factors that put a nerve at risk. We also know that there are obviously systemic pathologies that can affect nerves, as well as pharmacologic agents. We also know that there is a vulnerable variability of specific nerves. For example, in a sciatic nerve injury, there is typically a much more pronounced common peroneal nerve component dysfunction as opposed to tibial. So, when we think about patients, for example, that we're evaluating for hand weakness, as neurosurgeons, we have to think about the entire neuroaxis, right? Is this hand weakness coming from something like cervical spondylotic myelopathy? Is it coming from a plexus lower trunk tumor? Is it coming from neurogenic thoracic outlet syndrome? Or is it coming from ulnar nerve entrapment at the elbow? So, the clinical strategies that we employ as peripheral nerve surgeons really come down to good clinical judgment and using adjunct testing. And this really starts at a really thorough history and physical exam, and then using that imaging and electrodiagnostic studies as an adjunct to your diagnostic considerations. When we look at the literature, most of the literature is in double crush syndrome is in the hand surgery and plastic surgery literature, in which they've looked at case-controlled studies of patients who undergo surgery for peripheral nerve entrapment, the most common of which being carpal tunnel or cubital tunnel syndrome, as well as cervical spine surgery. This is a paper that demonstrates a minimum 18-month follow-up, and you can see there's a variability around the timing of when both procedures are done. And the outcomes essentially show that there is no difference based on the sequence of surgeries performed, but that there is a worse outcome in patients that have double crush syndrome as opposed to nerve entrapment alone. Phelan is quoted by saying there are very few operations that are as successful and rewarding as the operation for carpal tunnel syndrome. It works the majority of times. However, when it doesn't, these are two studies that were done looking at failure rates in carpal tunnel syndrome, and these patients were subsequently looked at and found to have concomitant neck pain and cervical degen disease, and perhaps that is a component of their failure. This is another study that was done looking at patients who underwent ACDF at C6, C7 for radiculopathy and carpal tunnel syndrome, both within 5 years. And in looking at functional and patient-reported outcomes, the conclusions were basically that patients that demonstrated this double crush syndrome, where they had both cervical radiculopathy and carpal tunnel syndrome, had worse post-op disability than nerve entrapment alone. And that the theory is that there's probably a high rate of undiagnosed cervical radiculopathy in these patients. And again, recognize these are done by hand surgeons. So if we do identify patients that have concomitant injuries, both peripheral nerve entrapment and cervical degenerative disease, what is the order of the surgeries? What's the appropriate timing of surgeries? There's no great consensus on this. However, in general, we try to start with the more symptomatic pathology. If it's unclear which is more symptomatic, we tend to defer to the lower morbidity procedure. This is a recent paper that was just published this month in Spine, looking at a retrospective study. This was done overseas in patients who underwent surgery for cervical degenerative disease, as well as nerve decompression surgery spanning a 20-year time frame. And they split the patient cohorts in a staged group versus simultaneous surgery group. The simultaneous surgery group, which was done by 2 separate operating teams in one setting, and looked at typical outcome measures and had relatively long-term follow-up for these patients. And what they found was these patients' neurologic symptoms improved after surgery. The simultaneous group had a significantly shorter total operative time, shorter length of stay, and shorter temporary disability, and that this may be a very reasonable option. Their cohort of note had lower comorbidities, and also their patients were much younger. So this might need to be sort of looked at a little bit more closely with your own patient population that may have these concomitant issues. So in summary, I think the outcomes for patients that have tandem lesions is really dependent on an accurate diagnosis. So really going back to the basics and making the appropriate diagnosis is key. You can certainly think about stage versus simultaneous surgery, and individual patient characteristics should guide the timing of that. These patients do need close follow-up to determine if they need that subsequent stage surgery. And then sort of a call to action for neurosurgeons who think about this a little bit differently than potentially, the hand surgeons who are doing the isolated nerve decompression surgery, to think about potentially looking at these patients from a broader perspective. Thank you.